Firstly, I'd just like to remind the members that these proceedings are being recorded, with the recording being placed on the website of the appropriate agencies for public viewing. Yeah, I will now take a roll call for the minute, and I would ask if members would confirm they're present when I call their name. Councillor Lynn.
Present.
Councillor McHugh.
Present.
Thank you. Beth Hamilton.
Present.
David Cheap.
Present.
And Dave Berry.
Present, Willie.
Thank you. Glenn Lloyd.
Present.
Jocelyn Lyle.
Present.
And I've received apologies from Raymond Marshall. Martin Sloan. We'll mark them as absent at this moment in time. That would conclude the roll call for the members who would be been attending the particular meeting. And item 1, apologies for absence. I've covered that so far. It then takes you on to declaration of interest, and it's whether or not any members have any declarations to the content of the agenda as it stands.
No.
Well, Willie, sorry, can I just go back to the roll call, because I don't think you picked up Christine Jones as Acting Chief Finance Officer.
Okay, thank you very much. Was Christine Jones present?
Yeah, present.
Okay, I'll mark you as being present. Thanks very much. So there being no declarations then, it takes you on to item 3, the minute of the previous meeting and action tracker. The minute of the meeting of 31st of January is attached for approval.
Now, I wasn't at that meeting, so I can't propose it. Would 2 people who were there like to propose in second, please? If indeed we have 2.
I'll propose.
Actually, maybe I should have gone through the pages like I normally do to see if there were any before we actually approve them. So I'll just quickly do that if anyone has any comments or thinks there are any inaccuracies in the minutes. So page 1, page 2, page 3, page 4, page 5, page 6. Can I have a seconder, please? Dave, thanks for that.
I'm just checking, Willie, I'm assuming it's okay for a non-voting member to be a seconder, because I'm just recognising there's no other voting members that are on. Dorothy's the only voting member that was actually at the meeting.
We'll certainly standing orders to allow for a non-voting member to be a seconder, but generally the minute is there before the committee themselves for approval. There isn't any division on that. So with that, I would imagine that the minute has been approved.
Thank you for that, Willie.
Thanks. With that, it takes you on to item 3B, the action tracker. This is submitted for noting and updating accordingly.
Right. So, any comments on this? I certainly just going through it. The first point here, the point about briefing notes. That's a red. I'm wondering why that's still red, given that it dates back to December 2022, and it seems to be a relatively simple question that needs to be answered here. Like, can these be issued or not? Would anyone like to comment on that? Dave, sorry, your hand's up. Yep.
No problem. So yeah, there's just one that keeps kind of falling off the line of sight there, Ken. So we'll pick up with Roger Menny on that one to confirm how we could do that in future.
Okay. What else was there? I was going to. Yeah, Dorothy, would you like to come in at this point? Your hand? Oh no, your hand's not up anymore. No, maybe that was the same point, Dorothy, was it?
It was, Ken.
Yeah, thanks. Yeah, I don't think there's anything else that I want to pick up on there. Although there was one in yellow that I thought should be green, but let's not worry about that. Can't remember what one it was. So yeah, next item, please.
Yeah, thanks very much, Chair. Item 4 then is Dundee Health and Social Care Partnership Performance Report, Quarter 3. This is for noting. It's a report by Dave Berry.
Yeah, there's an absolutely huge amount of information in this paper. So would you like to talk us through it, please, Dave? or someone.
Well, as I say, I'll pass
Lindsay's
that one
here
on
for
to
that
Lindsay's
purpose.
capable
Thank you very
hands.
much.
So.
Thanks, Lindsay.
That's great. Thank you very much. So the purpose of this report is to update the PAC on Q3 performance against the National Health and Wellbeing indicators and measuring performance under integration suite of indicators. Data is also provided in relation to social care demand for care at home services. So a summary of the data is as follows. So when compared with the 89 baseline, performance is poorer than the 18-19 baseline at Q3 for 18+ emergency admission rate of hospital admissions due to a fall for over 65s, emergency admission numbers from A&E for over 18s, emergency admissions as a rate of all A&E attendances for 18+, 28-day readmission rate, the percentage of care services graded good, that's an annual indicator, so it's the same update as previous quarter, and the rate of standard bed days lost to delayed discharges of over 75. So compared with that's the bad news. Compared to the good news is when compared with the 18-19 baseline, performance is better for the rate of emergency bed days for over 18s and the rate of complex or code 9, whichever you wish to say it, bed days lost to delayed discharges for over 75s. So when comparing across Dundee by LCPP, you'll note that there is still quite a bit of variation by LCPP, often with the more deprived LCPPs having the poorest performance. We did look at West End. It was noted at Q2 that the West End rate compared with the 89 baseline seemed to be very high. The rate of increase compared with 18-19 was very high. On a positive note, though, although the rate of increase was high, when we looked at emergency admission rate, emergency bed days rate, and rate of emergency bed days to delayed discharges for code 9, compared with the other LCPPs, the actual rate was low. It wasn't, however, low for standard delayed discharges, readmissions, and hospital admissions due to a fall. And that does need further investigation to identify why that's particularly high in West End. It's likely there will be different reasons and more complex reasons for that. It would need a more of a further in-depth analysis of that. Moving on to the care at home services, at 25th of March 2024, and this was the most recent data that we had at the time of submitting this report for the PAC, nobody waited in hospital and 150 people waited in the community for social care assessment. 20 people were assessed in waiting for a care at home package in hospital. This amounted to 314 hours yet to be provided. 25 people were assessed in waiting for a care at home package in the community, and this amounted to 110 hours yet to be provided. And for those already in receipt of a care at home package, 110 hours were required and had not yet been provided at that point. And you might also be interested to know that for indicators 1 to 9, which are detailed in Table 3, this data comes from the National Dataset for the Health and Care Experience Survey, and the data included in the Q3 report is for the previous publication at 21-22. So we're expecting the 23-24 data, it's a biennial survey, to be published towards the end of this month. So should that be published, we will be able to provide an analysis over the 3 years worth of data, which will be available to us 2019-20, 21-22 and 23-24. And we do have this tabled to come to the following Performance and Audit Committee.
I certainly think further analysis is welcome on all of these stats. There's so much deterioration in performance, although there are some improvements, and some of the improvements are not just in the better off areas. I think that the best performer within Dundee certainly is the North East Ward, which is one of the more deprived. The question that I wanted to ask is about Table 3, where you have a very bright picture painted on the first section, percentage of adult, well, actually, no, percentage of adults able to look after their health were very low. But if you go underneath that, we were 5th in Scotland in terms of adults who agreed they're supported to live as independently as possible. Number 7 percentage of adults who agreed they had a say in how their healthcare or support was provided. We're 2nd in Scotland. You know, I think you know where I am on the table, so I won't go down the whole list, but you know, a relatively bright picture is painted there. But then if you go on to the next one, percentage of adults supported at home who agree that their services and support had an impact on improving or maintaining their quality of life, we go to 29th. And the 2 underneath that, 26 and 20, which is, you know, that's a poor performance. So people seem to be praising the services they get from the partnership, but then when you go to it doesn't really tally with what's in the next section. I wonder, is there must be an explanation, but I'm not sure anyone has it. I certainly don't. Yeah, Lindsay, would you like to?
Sure. Okay, so the national indicators are very acute emergency admission based. When people are asked about their perception of the service that they're receiving, it isn't always about that. It's often about the community service and their social circumstances that they're living in that they're responding against. So that would be my, you know, assessment of why there's a difference there. I think it's 2 different things.
Okay, David, you're first.
Yeah, thanks, Ken. It's just, I know I'm completely new to this but I just wondered the relevance, to be frank, of comparing with the 18-19 baseline, how long that's going to continue. I mean, I appreciate it's pre-COVID, and then, you know, post-COVID, I would have expected now to be kind of maybe moving away from that historical comparison. It's such a long time ago now, and we should be focusing on how our growth is and how we're improving or not, based on probably 2022 going onwards. I would have thought. I just think it's. I'm not sure how much people are paying attention to what. I know generally, you know, productivity and everything is still low in certain areas compared to pre-COVID, but for reporting full reports like this and always using that as a baseline, I'm not sure how helpful that really is. It's just a passing comment. I don't know if Lindsay can comment on that or what. Thanks.
Lindsay, would you like to come back in? Yeah.
Yes, please. Yes, we have a legitimate reason for that. In the legislation, we have a statutory duty to report the previous 5 financial years, and to track that. Report that in our annual performance report and track that throughout the year. So that is the reason for the 2018-19 baseline. It's statutory. We do, however, track that longitudinally in table 3 by year, and obviously we track that in our quarterly performance as well. Until recently we were using the 15-16 baseline, so you would have liked that even less, but the reason for that was because of the COVID interference that might have caused to the data, and we wanted to be absolutely sure that that was the reason for the variation in the data and there wasn't something else. But over the last few quarters, we have been using 2018-19, but trying to present data as current as possible from then.
Okay, thanks, Lindsay. Thank you.
Welcome.
So it'll be a couple of years then, at least, before we're going back 5 years and it's post-COVID, because that was a very unusual time and must have had an effect on all sort of indicators. But it's the last 5 years and that we are where we are. So, Beth.
Thank you. Just a couple of points, if I may. The first thing is the complex code 9 reduction. That's very welcome. Is there some particular reason for that? I'm looking at Jenny, I suppose. Have we got a new care homes, or is it the care at home, or is there something that we're specifically doing, or are we just generally getting better with complex cases?
I think one of the impacts, and I'd probably want to look in the detail of this a bit more for you, Beth, but one of the impacts of the pandemic was to slow down the development of accommodation and things. So I think what we've had is a number of people who've been stuck for quite a long time able to move on.
Right, that's good. That's good. And the second thing is, it's quite striking when you look at the first table about the falls. I mean, the some of the percentages of the increase in falls. Is there anything that's specifically been addressed around falls? I know that
So yeah, can I come in on that as
yeah.
well, Beth?
Yeah,
There was
sure.
a report presented recently to the IJB that was about all the strategic work in relation to that. What we're measuring is the number of admissions relating to a fall, and what the analysis has shown is often they're not injured. So this is about kind of pathway development for non-injured fallers rather than there being particularly high numbers of people necessarily who are injured after a fall. But there is a strategy in relation to falls that goes right through from the very preventative elements around exercise and movement through to those pathways.
Yeah, okay, that's great. It's just such big percentages, aren't there? Anyway,
It's very evident
yeah,
that we have high numbers of people being admitted following a fall, but I think reassuring that many of them are not injured.
okay, that's fine. I'm a bit reassured by that. Thank you, Jenny. Thanks,
So
Ken.
it's just as a precaution then, the admission, yeah. Dorothy.
Thanks, Ken. Yes, I'm actually reassured by the falls numbers as well, because I think what we do is admit people probably more readily than other areas, and I'm quite reassured by that. I have a question on the report on Appendix 1 and on the longer one. What is it? Appendix 3. Anyway, on the report 5.2, which is about weights for social care assessments and care at home packages. There's 0 weighting in hospital for social care assessment and 150 at home. Should social care assessments not be done before a patient is discharged? That's my first question.
They are.
So with
I mean, well,
150 waiting at
before, I
home.
suppose you can't really do an assessment fully. So you complete the assessment at home, but that assessment is initiated before somebody's discharged. It's people who've not been in hospital that 150 is picking up.
I see. These are not patients who've been discharged
No,
home.
it's
Right.
people who may be shown as having a lesser initial need that are waiting for assessment in the community, but it's all kind of prioritised and monitored.
Right, okay. The other question I had on that was, how long are these waits? I think I've asked this question before. How long are people waiting at home for either an assessment or a home care package to be put in place? Do we have information on that?
I'm going to defer to Lindsay on the statistical element of that, but it will depend on the level of need that they're presenting with.
Lindsay?
So urgent ones will be picked up really quickly.
Lindsay, you're on mute.
Apologies. We can take that away and look at that and bring that back. If that's okay.
Thanks, Lindsay. I don't mean to cause you more work, but I would be interested to know, and I take Jenny's point that urgent ones would be dealt with first. I have a question on Appendix 1, which is this. Oh gosh, it's really red this time, isn't it? Is there I like trends. I like to see a trend, and we get that in other tables and reports. Is there any way we can have a trend on the Appendix 1 performance summary? Or is that a silly question?
I think we could have them side by side. I think that would be useful rather than having it much later on in the paper. Anyway, that's my take. Lindsay.
Okay, so table 1 is showing the change compared with the baseline year. So we have tried to provide the trend in table 3 under each of the indicators, showing the annual so the annual change and the quarterly change.
Yeah, I see that. I find this really quite useful because it's a 2-page summary, and then there's a lot more in the next table, and it's kind of marrying them up, which I find quite labor intensive. Anyway, that's okay. That's fine.
It's a lot of information. We could certainly go and have another look to see how we could better present it to try and identify how we. Well, I'm not sure that we can, because it's a lot of information on one page. But we'll certainly get our thinking caps on and see what we can do.
Okay, that's me giving you more work again, Lindsay. Sorry. And my last question on table 3 is on page 32 of the bundle. Number 20, percentage of health and social care resource spent on hospital stays where the patient was admitted as an emergency. I'm not really sure what that's telling me. Hospital resource or health and social care resource. What does that mean?
Apologies.
Sorry, point 20, did you say, Dorothy?
Number 20 on page 32 of the bundle.
Okay, yeah. Oh, yeah, I get it, yeah.
So this is a national indicator. The data has not been updated since 2021, you'll note. We haven't received anything nationally about this, but the denominator is the total budget for health and social care partnerships, and the numerator is the spend on acute care. And
so we're tracking cost
proportion
over time.
The proportion of cost.
Yes. Okay, that's fine. Thanks, Lindsay.
I don't see any other hands. So no further questions. As Willie said, this paper is for noting. I think it's duly noted. Thank you. Next item, please.
Okay, thanks very much, Chair. Item 5 is then Dundee Health and Social Care Partnership Clinical Care and Professional Governance Assurance Report by the Clinical Director. I'm thinking Jenny Hill speaking to this item.
Go for it, Jenny.
I think it's probably.
I think Matthew Kendall's actually on the call.
Yes.
Oh, really? Oh, yeah, there. Yeah.
I was expecting
just
to
appeared,
speak
Matthew,
to
I
this,
didn't
but
see you
I've been
before.
let off the hook at the last minute.
Apologies, I was slightly late coming in.
It's okay.
So this is the Clinical Care Professional Governance Report. This is the assurance report, and we are offering levels of reasonable assurance due to the factors that are highlighted in section 2.2. So I'll just draw out a couple of key areas. I'm not going to go through the full report, but we'll take questions. So I think our risk management processes have seen quite a nice improvement in our risk, particularly for our Dundee Drug and Alcohol Recovery Service in this reporting period. It's been really great to see that, because they have for quite some time been static and for quite some time been in significant difficulties in terms of supporting the staff and the patients in and around that service. So it's nice to see that we've got some change coming in and around that service. The service, as well as seeing the risks come down, are certainly seeing an improvement within their recruitment. They're actually getting some staff coming back into the service that have previously left, and they've been able to undertake some training, particularly with their medical staff, to support in the management of the DH&SCP and the local adverse event reviews as well. So it's quite nice that we're seeing a positive change there for something that has been static for quite some time. We've instituted across the partnership to supplement our Clinical Care Professional Governance Group, a risk management meeting, which is held in the intervening months from the CCPG meeting. I think this is having sort of a positive effect in terms of supporting people in making the link between the service risks and the strategic risks, and also staying on top of managing the risks in a more proactive manner as well, which I think we're seeing with this report there. The paediatric risk at section A4 has improved, but we've recently had some more clinical staff that have left that service, but there is an interview next week for that. So that risk will sort of remain as an item within this report until we've got that to a sustainable level. But it's there are good signs in place that is improving, and the more junior elements of the team are certainly in place now. We just need to secure the senior clinical leadership for that to continue to work well. Our workforce risks do continue as a problem across the partnership and across all of the professional groups. There are small improvements intermittently for this, but it's still an area of concern for us. I'm going down and past the information, the DATIX information. I just wanted to highlight the vulnerable adults, which is at section C10. We are seeing an increase in the number of vulnerable adult DATIXs being reported, which is a positive move in terms of making sure that our health staff are identifying and are reporting onto our protecting people teams and our adult support and protection teams. And this is a formal DATIX is now expected when those referrals are made. So we're starting to see that coming through in the system. That is necessarily a change in what people would have done before, but we're getting the assurance of that on a regular basis, which is quite nice to see. And then the last point that I wanted to just sort of raise down at C14 is in relation to the overdue verified events. This has been highlighted in the last couple of reports and indeed longer than that, that this is an area that we really feel that we need to see an improvement in. These are the adverse events that have been verified by staff but remain open and within the system. And you'll note on the table at C15 that some of those go back to 2019. So we are seeing some changes within there, particularly within our drug and alcohol recovery service. They're starting to work on some of their historical backlog, and then they've got their senior manager in place to support that. The majority that are outstanding sit with our mental health services, who do have significant staffing concerns with regard to both their medical staff but also their senior management staff. But the team are working hard with doing what they can around that. All of these have been looked at. We're aware of what all of these incidents are, and work is ongoing. But obviously our intention and our plan is that we'll be able to get these closed off sort of fairly soon. The very vast majority of those relate to a death of some sort, whether that's drug-related deaths or suicide. So the work that's required is fairly intense, it's very complex for the teams, and the timing is really important as well in terms of making sure that when we engage with families and relatives, we need to make sure that we do that at the most sensitive, appropriate time as well, and that can often put delays into the system as well. So there are good reasons why some of these are taking longer than we would like, but at the same time, we feel that we need to see a change in the numbers that we've got historically sitting in there. So that's all I wanted to raise to your attention, but I'm happy to answer any questions on the report.
Yeah, thanks for that, Matthew. I'm particularly encouraged by the risk trends shown at the beginning, which you referred to, the DDAR service, Dundee Drug and Alcohol Recovery Service.
Yes.
So it's great to see the risk trend decreasing, but more than that, if in the narrative, it's very encouraging, because people working in that area have been under a great deal of pressure in recent years. I think the Drugs Commission, in a way, was a double-edged sword. It had to happen, but it did put these services and the people who work within them under a microscope. And I think any commission has got to identify areas for improvement, which can be perceived as criticism. But I'm really pleased to see the morale rising within the service, and particularly the recruitment and retention, and that it's now becoming an area which is attractive to work in. So really pleased about that. One of the indicators here on DDARS was the negative media reporting, increasing reputational, clinical and safeguarding risk. I mean, I'm not sucking up to DC Thompson, because I think one of the reporters is present here today, but I've certainly in the last 10 years noticed a big difference in the way that the local media certainly reports issues around drug use and drug deaths. I think it's much less negative. I've actually found them to be quite supportive in their approach to try and support us in what we're trying to do with the terrible legacy of drug deaths. But I'm just wondering how we actually gauge that. How do we make? Yeah.
Yeah, I think that at the time that this was raised, I think the manager reflected on, I think, Sky News perhaps being present, and there were some very sort of challenging conversations that were held. But actually, it was the impact often on people that were applying for posts, and they would cite that the negative information they'd received actually put them off from actually accepting a post within the service.
I see.
Whereas now that's completely turned around and people are coming back to the service saying, do you know what, I actually had really good support in this service and I did enjoy the work, and the work that you've done has got that into a place where actually I want to come back and be part of that.
Great. I'll bring in David next, please.
Yeah, thanks, Ken. Actually, you kind of took a lot more words out of my mouth, actually, because I think it's really encouraging to see the trend here in particularly in that last quarter across most of the indicators on the drug and alcohol recovery service, because it has a clearly growing exposure, as you say, in the media as well, and it's one of the key factors for the work for the plan for NHS Tayside as well. I know that my colleague Martin Black on the board will be particularly interested in this information because he holds this very close and there's a real interest in this, so I'll take this back to him. But I think particularly that's really, really good news, and it should be picked up on hopefully in the media as a good trend forward. Thanks.
Beth, please.
First of all, I'd like to acknowledge that, I mean, it's been acknowledged in various other committees throughout NHS Tayside as well, about the Kingsway, and the good news reports, all three reports that are coming out, is very positive. I personally know the Kingsway and I know the conditions and the history of it, so I think it's amazing and I think you should be congratulated. I just wanted to point that out so we can pass back to the staff. Well done. The other thing that I was just going to ask, I noticed that there was the biggest complaint we received was disagreement with care plans. I find that quite encouraging in the sense that it's acknowledging that we are discussing care plans with people. Is that correct? Because I know that one of the problems has always been people not being involved in their care plans at all. But if the biggest complaints is now they don't agree with their care plans, are we seeing that as a positive step?
Yeah, absolutely. And it's like you say, Beth, we want to be able to have that person-centred approach in terms of planning care. We want to understand what people want to achieve from the work that they do with us, and particularly from my background, from a rehabilitation perspective, we want to identify what's important to people and what activities they want to return to, and then how we try and support them getting back to that. So yeah, it is positive, and it does show that we're having those conversations where we should be, in line with things like the realistic medicine proposals.
Okay, thank you for that. That'll do me. Thank you, Ken.
Yep, thank you. No problem. Dorothy.
Thanks, Ken. I have a question, Matthew, on C14, overdue verified events. And the heading is events being reviewed, awaiting completion by number of days since submitted to verifier. Is there any information on the time since the event?
It will probably be fairly similar to when it was submitted to the verifier. The standard that we try and operate to is that any event should be reported within 24 hours. That's right, where we're audited, and then they should be verified within 72 hours. Now, that's not always possible. So some of these, as I mentioned, would be relating to deaths. So sometimes the services would be informed of the death perhaps a week or two after that has occurred. So there might be a delay there. So the event may well be slightly longer than when it was reported. But largely speaking, the timeframes that we see on there would relate to approximately when the event occurred.
Okay. And one of the measures is over 180 days. Do we know how much over 180 days this could be?
Yeah, so down at C15, the table that's there, that's listing all the way back to 2019.
Oh, yes.
Yeah, so the oldest ones that we've got three that are from December 2019. They are our oldest ones in the system at the moment. They're all sitting with our mental health service. The other ones in 2019 for DDARS have now been actioned and closed.
Okay, that's great. Thanks, Matthew.
Thank you.
I see no further questions. So this report has been presented to us to provide a view on the level of assurance. The recommendation of the acting chief officer is that the level of assurance provided is reasonable, and lists the reasons beneath. I would agree with that assessment, that this provides a reasonable level of assurance. Is there any view to the contrary? No. Thank you.
Thank you.
Next item, please. Sorry,
Yeah, thanks.
can I just say that when I'm looking, if people think I'm looking at texts, I've got the agenda on my phone and on the papers, so I'm not looking at text messages. It's the agenda, just to make that clear. Carry on. Sorry.
You're all right, Ken. We believe you.
Yeah, just as also on that topic, when my head's going like that, I'm not falling asleep. I'm trying to read my screen when the diagrams are at a side angle. I'm not laying my head down, honest.
Okay, thanks everyone. Item 6 then is a quarterly complaints and feedback report. This is also for noting it's a report by Dave Berry.
Yep, Dave, go for it.
Yeah, so I'll pick this one up today. So it is what it says. It's the kind of third quarter report from the last year, kind of similar format that kind of members will be familiar with. In terms of the complaints, slight kind of increase in terms of the number of complaints that we've received over that kind of last quarter from both kind of social work and a health perspective there, but still kind of relatively small number of complaints compared with the kind of the number of contacts and services provided. But nevertheless, obviously each complaint is really important that they're investigated kind of properly. Around there, kind of similar trend in terms of the kind of responsive time, and there's slight deterioration in terms of that side of things. I think in terms of the kind of section 6, in terms of the complaint stages goes within timescale, we can see that for a stage 1 complaint, which is kind of really a frontline kind of resolution, that performance has kind of slipped a fair bit there for both the kind of social care and health side of things. So we'll kind of there's a connection here with between this and the risk report and Matthew's report. He's just kind of picked up in terms of the CCPG. So clinical care professional governance will kind of pick up on the performance here of the complaints side of things. And when it comes to stage 2 complaints from a social care perspective, and we're seeing a bit of an improvement there in terms of those being completed within timescale, and a kind of pretty kind of static kind of move around the sort of health side of things as well. I think kind of probably fair to say in terms of a lot of the stage 2 complaints, by their very nature, they are complicated and can often involve quite a number of different services, particularly around particular kind of pathways. So sometimes it's not a case of it's one person can deal with it. It's taking it all the way across the pathway. So there can be some challenges around that, but again, we'll continue to kind of pick up and report on those ones. As ever, we look at what we can learn from complaints, what we can do better, and there's an example there of what we've done following a complaint that was kind of upheld previously. And also, I think important to recognise that it's not just about complaints, about the compliments that the service receives as well. So again, we've highlighted some of those just for your information. There are many more, as you would expect, but these are just kind of few highlights. I think at the last meeting, Claire Lewis Robertson introduced, who kind of covers the complaints, kind of talked about the fact that we've kind of procured the care opinion kind of service to enhance our kind of complaints and feedback and quality assurance kind of processes here. So that is being embedded now, so we're already getting some really good kind of feedback and kind of using that to good effect since we've kind of put the care opinion in place. So that's a kind of brief overview of terms of the complaints, but can again, as ever, happy to take any complaints, any observations, comments, or questions.
Yeah, I think it's really important that we continue to have this item on our agenda, and that we monitor the level of complaints and what they're about and take action where necessary. Maybe there'll come a time where this report will come to the Performance and Audit Committee and there'll have been a massive spike in complaints. But I think every report shows a relatively low level, which is encouraging. And I hope never to see that day, but if it does, at least we'll know about it. Beth.
Thanks, Ken. It's interesting to see that they have the division between social work and health complaints. Is the rationale for that you're reporting into different employing organisation systems, or do you just find it easier that we have social work separate from health?
See, Jenny's coming in on that.
Yeah,
Jenny.
no, unfortunately, Beth, it's statutory, so we have to have those,
Right.
but we don't actually, if we get a complaint, we will respond to it holistically. We just route it through whichever one is most appropriate, but we can't actually go completely to a single system.
Okay, that's great. Thanks. The other thing I was just going to say is it's good to see care opinion, because it definitely is nice to be able to see some of the positive stuff. Before we had to depend on cards and things that we couldn't actually record, but to see the visible positives as well as the negatives is very welcome. So that's good. I'm pleased to see you're on that. So thank you.
Dorothy.
Thank you. I've got a question, Dave, on care opinion. It says we're already receiving stories from patients and service users. How do these stories come through? What how does that actually work?
Explain yourself, Dave. Explain yourself.
Jenny will come on this one as well.
So I don't 100% know, but I think I maybe know slightly more than Dave. There's contacts for services, I think, on it that are notified whenever anything's posted about their service. Matthew probably knows even more.
So a patient or a service user would have to go online
for care opinion. For care opinion, that is an online platform, but there are obviously other ways through the feedback team and things that we can receive opinions from service users. So it's one way, but it's not the only way.
And the other way that you receive stories or opinions is that, will that be included in any report statistics, that will be produced from care opinion?
Yeah, for quite a long time. Well, no, it won't on care opinion, so it'll report separately, but for quite a long time we've kept kind of a register of compliments that come in.
I see Lindsay's wanting to come in, and as well as Dave. Lindsay, would you like to comment?
Thank you. In our annual performance report, we try to include as much patient service user stories and examples and case studies as possible. So that's one area where that is recorded, but on an annual basis.
And Dave?
Yeah, thanks. And yeah, Dorothy, Claire Lewis Robertson had picked up kind of previously around those that are not kind of online or find it difficult to access, and is looking at how to exploring that with kind of care opinion around how we'd be able to support people to do so. Whether it's kind of an offer of kind of additional support to enable them to do that. So we'll pick up that again offline and get back to you on that one.
Yes, that's actually what I was trying to get at, Dave, because a lot of older people, won't be online and they'll be heavy users of social care. So thank you.
And last but not least, Beth.
Yeah, Dorothy, I just wanted to clarify, because I was involved when this was getting built up years ago. Care opinion, it's the biggest thing about it is it's interactive. So if somebody puts up an opinion or a complaint, there should be somebody in each organisation that monitors that on a regular basis and will be able to respond to that for the people that are putting something up in care opinion. And I think the point is that if there's somebody's got an opinion, they're supported to put that in, and then that becomes part of a system and it's interactive and you should get responses. And you yourself could go in and look at care opinion and look at how it's doing in your hospital areas. I don't know if it's worth giving people the link that the people can go in and look. Because the more people that have it, the more people will use it and the more information you'll get. Sorry, I sound as if I'm getting commission from Care Opinion, but it is a very useful tool. And the information, the more you have, the better it is. But it's a really good system, and you know, a lot of people get a lot out of it. So I would suggest, Dorothy, get the link and go in and have a wee nosy.
I guess
Yeah,
you
that
could-
would be useful, but I
Sorry.
think the main point I'm trying to make is that a large percentage of older people are not online,
Yeah.
and their opinions, of course, need to be gathered. But Dave's going to look into that for me, aren't you, Dave?
He's a good lad.
Absolutely.
Yeah, I'll certainly have a look at Care Opinion. No one needs to send me the link. I think, well, hopefully just by Googling it, I'll be able to find it, because it should be easy for people to find without having to ask for a long link. Anyway, this report is for noting. Thanks for your contributions. Can we have the next item, please?
Yeah, thanks to your item 7 then is the D-Health and Social Care Partnership Strategic Risk Register update. This is also for noting as a report by Dave Berry.
Okay, over to me
Yep.
again. Claire's on leave this week, so I'll pick up on the risk side too. So again, as I mentioned, kind of ties in with the care clinical care professional governance report. This is the latest kind of update on the IGB strategic risk register. Has been updated kind of very kind of recently, so kind of end of April. We've kind of gone in and reviewed all the strategic risks again. So and there's a bit more narrative in the report around the risks and kind of the some of the impact of some of the scores. As it says in the report, we've got our two highest risks remain around the staff resource. So while there has been some improvements, as Matthew said, in some services, there's also still kind of a range of services that we're still kind of hard to recruit to. And also we've kind of escalated the lack of capital investment in health and social care facilities following the Scottish Government's budget implications around capital, which have been kind of well publicised across the country. So the restrictions on capital going forward for the next couple of years will kind of reduce the opportunities that we'll have to kind of to enter into sort of larger scale developments, reshaping non-acute care for older people is one of the services, one of the projects that we've had to kind of put on hold just now because of the overall funding position. So we've kind of put that up to the highest kind of level of risk as well. Excuse me. Our financial risks remain quite high as well, as you would expect, given the financial kind of environment that we're working in. So they remain at kind of level 20 at the moment. And similarly, we've kind of got a risk around primary care sustainability. We had the recent closure of Park Avenue Medical Practice, so we've still got some risks around the system around primary care. We had increased the capacity of the leadership team risk following the retirement of Dan McCulloch and the kind of current acting up arrangements that we've got in place across the senior leadership team. Although I'm kind of pleased to say that we have recruited internally on an interim basis to the head of health and community care kind of role. So Angie Smith, who currently works as an associate locality manager within the service, has been recruited there and has now started. So that gives us that kind of increased kind of capacity again at the senior level. So we'll review that risk as well. So a number of other kind of risks that have kind of increased data quality risks and increased bureaucracy. We're kind of keeping monitoring those side of things. The increased bureaucracy really around what we think might come if there's anything else around COVID inquiry, but also the National Care Service development as that kind of starts to kind of develop over the coming sort of months and couple of years. The We've actually decreased the risk around the National Care Service. May sound a bit strange that we've done that because it's still on the table. However, the risk was more around the IGB itself, and the fact that previously it looked like IGBs were being abolished completely and replaced, but it looks like they're now being reformed. So we've kind of reduced the risk around that in terms of the fact that we'll still be here, just in a slightly different kind of way of doing things. So we've kind of we've reviewed that accordingly. We have got a new risk, and we've just introduced following some changes to Dundee City Council's IT system, so some necessary kind of upgrades and modernisation there. But there's been some knock-on effect, or anticipated knock-on effect, on the way that we've kind of worked in an integrated way. Because we've, over the last few years, we've found ways of working across systems for teams working across IT systems that have now been affected by some of the changes. So again, we're working our way through those just now, but we thought it was worthwhile kind of putting that down as a risk. And we've archived a couple of risks as well, so specifically around the planned performance management improvements. So one of the other reports that I've got next, kind of we'll cover that one, and also the direct impact of COVID-19. We still have some of the indirect kind of impacts of that, but in terms of that, the kind of the COVID-19 pandemic impact, we've kind of removed that from our risk register as well. So hopefully that gives members a good kind of oversight in terms of the where we are in terms of the risk register. And we do still have to kind of go back as an IGB to set our risk appetite levels. We've had to kind of defer some of the work on that over the last kind of few months because of various pressures and capacity, but it is down as one of the development sessions that we'll have in place over the coming months as well, and that'll kind of help enhance our kind of our risk management arrangements going forward. So yeah, happy to take any questions on these ones too.
Yeah, thanks for talking us through that, Dave. Dorothy.
Yes, thanks, Dave. And I'm so looking forward to a development session on risk appetite. You know, I'm so interested in risk. I'm trying to get my head around it. I have a question on 5.4, lack of capital investment. Now, I know this report is about risk and levels of risk, but in practical terms, I wonder, you know, about the effects of reduced investment, and will we get some further detailed information on this at the IJB? The implications of this?
So, I think one of the issues is so capital funding is not delegated to the IGB. So, any access to capital funding we have to kind of, as a health and social care partnership, is access through both the council and NHS to decide. So, the financial implications, the direct financial implications, are actually their financial implications as the kind of the bodies that have the capital funding. So it's not like a revenue budget that we get an allocation and we as an IGB decide how that works. In terms of the implications, I think we've probably already picked up within one of the primary care reports the impact on some of the primary care premises work, because the allocation of funding is remained static, but there's also some issues around what are called the lease assignations from a primary care perspective, and restrictions on how that might work kind of going forward. So there's a wee bit of a bit of limbo in terms of that side of things. In terms of most of our capital, or one of the big kind of opportunities we were looking at within capital sat within the NHS side of things. This particular risk was put on at the request of the previous chair, Pat Kilpatrick, in terms of kind of looking for us to kind of in Dundee to have similar facilities as there has been across the country in terms of sort of kind of multi-purpose community hubs and the ability to do that. So the risk around that is when we look kind of forward over the next few years. Scottish Government says there are no new developments that will be kind of happening unless they've already got to a certain stage. Now, anything that we've had, excuse me, within Dundee has not reached a kind of particular stage in the Scottish Government's eyes, so they're not even cited on a lot of these. So it's more about the potential opportunities that I've lost rather than things that we'd already agreed at the IGB that we were going to be doing. So in terms of governance around that, it's probably more just an awareness of rather than a particular this will no longer happen because sort of thing. We might have, I'll pick up with Jenny around what we've reported previously around reshaping non-acute care project kind of formally to the board, because we may need to kind of go back on that one in particular. But yeah, it's a slightly different, capital slightly different from our revenue, because we do have to ask for that. So
okay, thanks, Dave.
I think I'll bring in Martin next. I haven't heard from you this morning, Martin. Yep, do you want to ask your question?
Thank you, Chair. Yes, it was a bit late this morning due to Teams issues.
Oh, no problem.
Just a couple of quick questions on the IGB, the National Care Service. Now, Dave, you mentioned that the idea is that IGBs are not getting abolished; they're getting reformed. So you've dropped the level down. My understanding is that we are that IGBs will be continuing, but in a slightly more slightly different form and different structure. Is that what the information you have in relation to that? Is that the reason why you've dropped it down? Because I think, in my mind, I think the level that we had at was high was an appropriate level. And my other question or statement was regarding the data and IT systems. In terms of the data quality, I was a little bit I've got quite a few questions about that, which I think I'll take offline and email directly to you or to Claire or whoever, because I think there's a lot of new systems coming on, especially in terms of machine learning and IT, which could benefit the analysis and the work that is happening with around data. Because I know that a number of organisations around the country are starting to implement AWS quite extensively, and their AI systems. And I know that with Oracle, their latest version that they've come out with is very heavily reliant on AI and AI development. So it would be interesting to see how that systems could be actually implemented. Because I know you're moving away from Oracle to SQL, which I think is a bit of a downgrade in terms of the underlying data, the database that will be managing the data. So it'd be interesting to probably contact Claire directly on that, but just to highlight some of the concerns I have around that.
Okay, thanks for that, Martin. So I'll pick up National Care Service kind of side of things. So yeah, we so the reason it was previously at 25 was because we thought was the highest risk that you'd completely abolish the IGB. So you can't get a bigger risk than not existing over time. So the reason we've dropped it to 20 is because we still don't know. We still don't know enough around what that reformed IGB is going to look like in terms of purpose, membership, even things like kind of chairing. There's talk of potential independent chairs, etc., etc. So there's a whole load of things that are still unknown around the National Care Service and what it's going to look like. So we've kind of still kept it at kind of quite a high risk level until we get the certainty around what it actually means around that. In terms of the data quality side, yeah, absolutely kind of happy to kind of pick up kind of separately on some of those issues. A lot of what we're finding is actually it's around the input into our Mosaic system from sort of the front line, understanding people are kind of pressurised in terms of day-to-day business and try to kind of do that and try to kind of manage so many different things. So a lot of it is around the sort of focus on how we make sure that sort of front end, that the data that goes into the system is accurate and as accurate as possible for lots of different reasons. So it can, you know, in terms of obviously record keeping purposes, financial billing purposes, kind of performance information that Lindsay kind of presents back to committee. So so a lot of the focus is on the what's actually going into the systems, but kind of happy to look at some of the other aspects around you know, that could help kind of support that. And then obviously there's the other aspect around the kind of the new risk around the kind of change over to new systems and what that impact is. So again, happy to kind of pick up with you separately on that, Matthew.
Thanks, Dave. Beth, you're up next. And you're on mute.
Thank you, Ken. One of the issues that I've been quite heavily involved with this environment is the cybersecurity risks that are pretty prevalent. You'll hear in the media about a lot of the stuff in Dumfries, etc. I was wondering, is cybersecurity not a bit of a risk for us as well, or is it because your systems are provided by the Health Board and the Council that cybersecurity is their risk and not our risk? But I'm just wondering, I think the prevalence of it, you know, seems to be growing. And I just wondered if it's worth us acknowledging that. And, you know, it goes in the back of Martin's conversation there about all the different systems, and the more complex AI gets, the more dangerous the risk of cybersecurity can be.
Yeah, I mean, you're absolutely right. I mean, the cybersecurity risk is one we would expect the partner bodies to be kind of hosting, because it is their, you know, it's their systems that we're using. And from an IGB strategic risk register, so this is not about the Health and Social Care Partnership, this is about the IGB itself. We need to ask the question, what risk does that pose to the delivery of our strategic kind of plan and objectives now? So I think it's a really kind of important point, because I think there's something that we maybe need to acknowledge in the risk register, or things that are not directly under our control. And so the mitigating factors, for instance, we can't really do that other than to kind of ask that both the council and NHS take side and make sure they've got the various firewalls, etc. within that. But I think it's worth us kind of noting, probably on the risk register, that there are a number of things that are a risk to the hosted bodies that will have an impact on us. So I'll pick it up with Claire around how we might want to kind of at least make reference to that, whether it's in the reporting or kind of recording of risk. So,
okay, thanks for that.
I see no other hands, and this report is for noting. Thank you. Next item, please.
Thanks very much, Chair. Takes you on to item 8, indeed, Health and Social Care Partnership Finance and Strategic Services Capacity. Again, it's a report by Dave Berry, and it's for noting.
So yeah, back to me again. This hopefully the final time you'll have to listen to me. And it was just a report today. We've taken this paper back. This was kind of one that came up from our action tracker, one of our kind of previous sort of discussions at PAC, where for a number of kind of threads, we've kind of noted that things had been delayed because of kind of lack of capacity within the services to kind of deliver. So I did say we would kind of bring something back to advise members of what we were doing about it. So this report kind of gives you an overview of the sort of restructure work that Catherine and I have been kind of taking forward within the kind of finance and strategic services service. So you can see from the report, I'll not kind of read the report, but you see that we've kind of largely, the resources that we've kind of got now are largely the same as what we inherited back in 2016 in terms of the kind of service. So what was really sort of core from the previous social work departments kind of service around strategic planning and performance and information, and also a kind of very small resource that kind of came over from the former CHP, and we've used that resource all the way through, but as the complexities of integration have become more prominent, and even through the formation of the park and the kind of and the work that the kind of park generates in terms of information, etc. We've kind of come to the point where we just can't sustain everything, because we're only able to do the kind of basic sort of statutory kind of responses and kind of provide information to the park and other bodies that request it. So that whole kind of ability to support services better in terms of their service planning, etc., has been kind of restricted by the lack of capacity. So we've worked over some time now to kind of relook at what we think the service actually needs, and have kind of gone through quite an extensive consultation process, including with our staff team as well, to develop a structure that gives us that additional capacity where we need it. And we're now at the stage of, we're starting the pieces of the jigsaw are starting to come together on that. So we've kind of filled a couple of posts. So both Lindsay, who's on the call, and Claire, who's not with us today, have been successful in getting the positions of kind of lead officer for strategic planning, business support, and quality data and intelligence. So that's the kind of the start of it, and then we've kind of started to kind of fill in the roles kind of below that. So there are some new kind of posts on the structure. Just obviously from a chief finance officer perspective, for both myself and Christine, we've kind of assessed the affordability of those within this sort of challenging environment. There's no additional cost or no additional requirement that we're asking the IGB, for instance, for to kind of divert money to. It's all done within reprioritisation and refocus of existing resources that we've got. So we continue to kind of work through the the implementation of that structure just now, and hopefully we'll be in a position over the coming months to kind of you'll start to kind of see a lot of these things that we've promised to do starting to kind of come to fruition.
Thank you, Dave. Martin.
Thanks, Chair. Just to first of all say well done, Lindsay and Claire, for their promotions to their new roles, and hopefully they'll be as successful in these new roles as they've in the past ones. The other thing I would just like to say, looking at the organisation chart, and I just have to say a lot of good posts there that are coming through, specifically in the data and intelligence section. Lots of really good information type roles that I think would be really useful. But again, I would like to add that I think we should be looking at how we can develop within the data intelligence, the use of machine learning and AI in terms of that works. I think that would be a good thing to see that within the roles rather than just as a bolt-on, to see it actually integrated into the roles. And I'd just like to say it's nice to see that there's a data intelligence officer for carers and personalisation. Good to see that it's been separated out from the role of existing and making it something separate, because I know there's going to be a lot of data developed over the coming time.
Okay, thanks. Dorothy.
Thank you. And thanks for this. I'm glad to see this expansion of resource. It's badly needed, and it'll be very welcomed. At 4.5, it says the approach has been taken in collaboration with the existing staff group. Was there any involvement of the trade unions in this restructuring?
So Catherine's on the call. I don't know if we were. I mean, I think in terms of the establishment change note process, there is the automatic sort of consultation with the trade unions. But Catherine, remind me, in terms of the discussions with the staff directly, did I think we'd given the opportunity for them to kind of consult their unions if need be? Is that correct?
Absolutely, and some members of staff did that as part of the process in terms of individually taking advice. We also obviously discussed this as part of our kind of regular conversation with trade union staff side through the staff partnership forum and our HR meetings as well. So there was that both individually and then collectively as well. And I know some, as I say, some staff did take some advice from their union as part of that process, which was really helpful in terms of a kind of collaborative approach. So we welcome that very much.
Thank you. Thank you.
Yeah, thanks for that. No further contributions, and that's for noting. So next item, a final item perhaps, other than attendance. Oh, is it back to you again, Dave, for the final item? I thought you said you were finished.
So over to Christine this time.
Oh, excellent. Hi, Christine.
You get to hear from me very briefly. Yeah, I'll very quickly introduce this, and then I'll pass on to Jocelyn Lyle just to take us through any bits, and happy to pick up any questions that anyone has. So yeah, just a regular progress report on the internal audit plan. And some and highlights within the report as well of reports that have been shared with our partner body NHS Tayside, just for highlighting that as to how these might impact onto IGB. Jocelyn, do you want to take us through the sort of key parts? Thank you.
Yeah, that's great, Christine. Thank you, and thank you, Chair. So as Christine said, the report sets out the progress with Dundee City IJB with the internal audit plan for 23-24 and any relevant NHS Tayside reports. We don't have any from Dundee City Council this time round. If we could just jump ahead to Appendix 1 of the report, which sets out the progress on the plan. So in terms of outstanding audits, we've got D424 governance and assurance. And there's a bit of an update at the next agenda item as to what's happening with that, and there'll be another report coming back to this committee in September. D524 is our internal control evaluation work. I really had hoped to have that completed for this meeting, but we've had some delays, both because of resource challenges within the internal audit team, and we're waiting for a couple of final items to come through to inform our work, and that includes the draft governance statement. Having said all of that, the rest of the field work is complete, and the draft report's been through our internal review processes. So we're going to be issuing that really shortly, and it will be presented to the June IJB itself, because we don't have another meeting of this committee. I think that we'd hope to do the ICE a bit earlier in the year. And I think what we have achieved is we got the work done before year end, before the pressure really comes on. And it's given us a really strong foundation now for our annual report work. So it'll help inform that. Apart from that, we've got D624 workforce, and at the moment officers are currently reviewing relevant risks. We're waiting for management agreement of the scope of that audit to get cracking on that one. And that's the only one that's really outstanding from that plan. So in terms of those reports from partner organisations, just two from NHS Tayside, one of which is the internal control evaluation, and the other is whistleblowing, and both of those provide reasonable assurance. For anyone who hasn't seen the NHS Tayside internal control evaluation, you can pick it up on the website. And it's probably I think it's quite a good read anyway, a good summary of everything that's happening within the control environment in NHS Tayside. So that's all I wanted to highlight, but I'm happy to take any questions on the report.
Are there any questions? I don't have any questions other than to thank you, Jocelyn and Christine, for speaking to the item. That concludes this item, which is for noting. And I think we're on to attendances now, Willie, is that right? Yep. And date of next year.
Sorry, Chair, just prior to that, we've got item 10, which is the agenda note and the governance action plan update, which is also for noting. That's all.
Yep.
Yeah, I'll just quickly pick this one up and just to highlight, as Jocelyn just said, obviously this is an outstanding item that we've got, and hopefully it will come to pack in September. It's obviously been something that's been on the go for some time, and should have come to this pack, but predominantly linking back to the previous item due to some of the significant IT changes that have happened recently, and the resource implications in terms of managing through and working through that IT, then we've had to obviously divert our staffing, our resources to concentrate on that, and have to put this one, unfortunately, to one side for a short period of time. So it was just to highlight that as part of the agenda note, and for noting for PAC members that, and we will get back to it.
Yeah, it's just made aware of that. Thanks, Christine. Willie.
Thanks, Chair. That takes you on to item 11, attendance list, which is for noting.
Unless anyone is listed as being not there that was there and wants to correct that. No, probably not. No.
And then finally, the date of the next meeting, which is Wednesday, 25th September, 10 AM. That would conclude all the business, Chair.
Okay, thanks, Willie, and thanks everyone for your attendance this morning and questions and speaking to the reports. See you all soon. Bye.
Thank you.